Hello everyone. I wanted to make a quick video on RSV, Croup, and Epiglottitis. We're coming into respiratory season, especially for the pediatric population. I've recently heard that Helen DeVos Children's Hospital has an influx of RSV patients and realized that a lot of people don't know much about these three disease processes. So this video is going to be just a quick down and dirty introduction of each disease, some quick treatment options, and if you have any questions at the end, you can always reach out to me. Okay, the first thing we're going to talk about is RSV. RSV stands for respiratory syncytial virus infection. RSV is the most common cause of bronchiolitis and pneumonia in the young population. I want you guys to keep in mind that oftentimes viruses and bacterial infections, although benign in themselves, or they oftentimes don't get too serious in themselves, they can lead to more serious complications in the young, the elderly, and those patients that are immunocompromised. So, and that's true for RSV as well. So the most common cause of bronchiolitis and pneumonia, typically in children younger than 1 year of age. Who does it affect? It affects the premature babies, those with chronic lung diseases. Oftentimes you'll see it in patients that are less than 3 months old. Again, patients that have immunocompromised problems. The symptoms are very benign in themselves. So this sounds just like the common cold: runny nose, cough, sneezing. They'll have a fever. They may have some wheezing later on as the disease process gets a little bit worse. So RSV is very contagious. So it's oftentimes spread directly. So if you come in contact, or your child comes in contact with somebody who has RSV, they can spread it just from being in close contact with each other. The other thing though too is RSV will stay on hard surfaces for many hours. So we can touch a doorknob, go home, and we can potentially give it to our kids or other people in our home. So we have to be very careful when dealing with patients with RSV. PPE is going to be of utmost importance. Typically, these patients will go through the entire disease process just fine, and they don't ever have to call 911. Oftentimes, when we are called, it's because now they're having an increased difficulty breathing, and that is where the big issue comes in. So I mentioned that RSV leads to bronchiolitis, or could potentially lead to bronchiolitis in the young population. So I really quickly wanted to talk about bronchiolitis. So bronchiolitis is inflammation and mucus in the bronchioles. It sounds a lot like asthma, doesn't it? The difference though is that asthma is an acute process, right? They have an asthma attack, and that's why we're called. With bronchiolitis, due to RSV, they've had these issues for a little bit of time. So oftentimes when we're called and we get a good history, because we're good history takers, we find out that this patient has been sick for a couple days, runny nose, maybe a cough, definitely had a fever, and now they're having difficulty breathing. We listen to lung sounds, and we can hear wheezing. That's typically going to be bronchiolitis. Okay, the next one in line is croup. Croup is a very interesting disease process because oftentimes it sounds a lot scarier than what it really is. So croup is brought on by a viral infection. It's pretty prevalent in the winter or fall months, and it affects kids from 6 months of age to 4 years. We have some people in the department whose kids actually had croup. If you want some good first-hand knowledge on it, talk to Lieutenant Gear. So what's croup? So oftentimes these patients get this viral infection, again, a runny nose, maybe a little bit of a fever. They go to bed acting fairly normal, and they're acting normal. They get up in the middle of the night and they scare the crap out of their parents because they go to the parents' room where they're crying and they sound like they have a very hoarse voice. That cough that they maybe had earlier, or maybe it's new, but the cough sounds like a seal bark. So it's a very prominent cough. You definitely won't miss it. You'll know exactly what it is when you hear it. They could progress into some wheezing if the infection starts going down in the lower airways. But again, oftentimes, because we're good history takers, we find out, hey, they've had perhaps a little bit of a fever for the last couple of days, definitely a runny nose, or just stuffy nose for the last couple of days. It's colder out or cooler out, cool nights, and a dry night. we laid this patient down or this child down at night, and then they woke us up in the middle of the night because they're having difficulty breathing, or they have this really scary sounding cough, and they're fussy, and that's when we get called there. So that is croup. Okay, the next thing that we're going to talk about is epiglottitis. This is a very scary disease process, one that we can't take lightly. This is going to be an acute infection, so sometimes parents realize that before they put the kids to bed, maybe they were acting a little goofy, a little fussy, perhaps they had a little bit of a stuffy nose, but otherwise this is going to catch the parents off guard. And so similar to croup, oftentimes this is going to happen in the middle of the night. So they put the kid to bed and they wake up in the middle of the night because their child's having an issue. Epiglottitis is caused by bacterial infection. And the reason why this is such a dangerous thing is because, again, it's an acute infection that causes inflammation of the epiglottis. So you can see here in the illustration on the right, on the picture with labeled A, that's a normal epiglottis there. So that's a nice looking epiglottis. If you look at B, that epiglottis is very, very inflamed. And you can see that now the opening to the lower airways is a lot narrower. And so if that continues, obviously now we're going to have a patient who's going to be unable to breathe. This affects kids in the range of the 3 to 7 year of age. Again, that's just a range. You can always have outliers. Similar to croup and RSV, this is going to affect kids in the winter months or the months that have the really cool, dry nights. Okay, so what are the hallmark signs of epiglottitis? We're going to have stridor. And why are we going to have stridor? Well, with the epiglottis, that's an upper airway thing, right? So that's a very anterior portion of the airway. If that gets inflamed, you're going to have stridor, and stridor is indicative of an upper airway obstruction. We're going to have drooling. The reason why we're going to have drooling is with this patient, the only thing they're going to be able to focus on is really just breathing. And what's going to help with that is having an open mouth and just breathing as easily as they can. They're going to have a very sore throat, and so they're not going to want to swallow either. And so when we get into a house with a patient with epiglottitis, we see a patient who's sitting very upright, open mouth, and they're just drooling. That's kind of the hallmark signs of epiglottitis, and we need to be very cognizant of that. Another sign is they're going to have an acute high fever, and this is just not a normal fever, right? This is one that has spiked quickly and is quite high. They didn't go to bed with this fever necessarily. So how do we assess these patients? So oftentimes these 3 disease processes are going to affect the young population, right? So our pediatric patients. So it's a good idea to use a pediatric assessment triangle. When we enter a house, we need to be very cognizant of what we're doing, what we're saying, our tone of our voice. Remember, we're strangers coming into somebody's house, and these kids are sick. They are already fussy, and they already have that stranger danger personality. So we need to make sure that we can do as much of an assessment prior to getting right at the patient's side. Ask a bunch of questions to the family when you're walking into the house, and then slowly make your way to the patient, and just be very cognizant of what you're doing and be very observant. So we're going to use a pediatric assessment triangle. Again, that's going to be an across the room assessment. We're going to assess 3 things. What's the patient's appearance? What's their work or breathing, and what does the circulation look like? So the circulation to the skin, what does that look like? So what does appearance mean? Well, is our patient very listless? Are they crying? Are they moving around? Do they trace us while we're walking towards them or walking around the room? Do they acknowledge that we're even there? Or are they just kind of very limp in the mom's hand, or mom or dad's hand? What about their work of breathing? So what can we notice from a patient's work of breathing from across the room? Well, sometimes you can have audible wheezes, but we definitely will be able to identify if they're using accessory muscles, right? So in the pediatric population, what does that look like? Well, that could be nasal flaring, that could be belly breathing, maybe their sternal notch is being sucked in every time they breathe. How about grunting? Grunting is a good indication that they're having a hard time breathing, especially for the super young population. Head bobbing is another big thing. If every time they take a breath in and out, their head bobs, that's an indication that, hey, there's something wrong. This might be a little bit difficult to assess, but if they have any tachypnea, so if their respiratory drive has increased, again, that might be a little bit more difficult to assess from a distance, but that's something to be cognizant of as well, right? So what is the pediatric or any body's first mechanism to start fighting things, is fighting a problem, is they're going to increase the respiratory drive. And then we're going to look at the circulation to the skin. So from across the room, are we able to identify that the patient looks very red, maybe potentially because they have a fever? Are they very pale, which would be a bad indication that they have very poor circulation to the extremities or to the skin, right? Are they cyanotic? Are we able to see any cyanosis around the mouth, around the nose, eyes, or in the fingers and the hands? Can we look at that from across the room? Maybe, maybe not, but that's something I need you guys to look at, or at least try to start looking at that while we're walking towards the patient. I want to remind you that if the patient fails any one of the sides of the pediatric triangle, they're automatically a priority 1, okay? So if we get into the patient's house and you know what, they're staring at us and they trace us throughout the room, the circulation looks good to the skin, right? Nice warm pink, apparently dry skin. But they're grunting, we hear stridor, we hear some audible wheezes from across the room, that's going to be a priority 1 patient, okay? Again, if maybe the breathing looks fine, the circulation to the skin looks fine, but they're limp in the mom's hands, that's a priority 1 patient. So pediatric assessment triangle, very useful tool to use, again, to assess the pediatric patient. This pediatric assessment triangle and a description of it is in the MyMedic cards, so please flip those open either on the way to the call or as soon as you get to the call. And it's a good idea to flip that open to the patient's proper weight as listed by the Broslow tape. And the reason for that is because that's going to tell us the normal vital signs for these patients, right? The normal heart rate, blood pressure, respiratory rate, things like that. And so that's going to be a good tool for us to use. So how do we treat these types of patients? First off, I want you to look at the picture on this child on the right. So we have a child that appears to be just staring off in the distance. Mouth is open, they're sitting upright. What did I say that was indicative of? So that's the epiglottitis look that I want you guys to look at and to identify when we're walking in the room, okay? So how do we treat these patients? Well, lots of calming reassurance. I know that seems silly, but actually it's usually the best tool. If we can get in there, be nice and calm, not only for the patient, but whoever the caretaker is as well, we're going to do a lot of good. I always say whenever we go to a pediatric call, we have at least a minimum of 2 patients. We actually have the pediatric patient and then whatever caretaker they have, right? And if we can't calm the caretaker down, that pediatric patient is only going to feed off of that, okay? So nice, good, calming reassurance, especially if this patient has epiglottitis or any kind of respiratory issue where that's really, really severe. We don't want to increase their need for oxygen because we're working them up, okay? Which means let mom, dad, grandpa, grandma, whoever's there taking care of this child, let them hold the kid. We definitely don't need to hold them, and if we do, we're probably only going to scare them more, okay? I have blow by oxygen there. In reality, blow by oxygen, it typically isn't the best. It doesn't do the greatest job of delivering good oxygen to the patient, but if that's the only thing we can do without causing more irritation to the patient, then let's go ahead and do that, right? We need to identify when this patient is in respiratory failure, okay, or when they're in really bad respiratory distress. We need to identify when we have to start ventilating this patient. So use the pediatric assessment triangle, monitor the ABCs, do the minimum necessary to get a good picture of what's going on with this patient, good history taking, right? If you believe that taking a blood pressure is going to irritate the patient too much and they're already having a hard time, let's go ahead and DC that idea for now until we can revisit that, okay? But monitor the ABCs with a pediatric assessment triangle. If we believe that this patient does have epiglottitis or other things, we can update ALS as well, okay? Again, use a lot of calming reassurance. Use the people around you, whoever is familiar with the patient is familiar with them, use them as a tool as well. Perhaps they can take a pulse ox for you or a pulse for you or a temperature for you. Perhaps they can do these things. Maybe they can hold the non-rebreather to the patient's face. Allow them to do as much as possible because that's really going to help you in the long run, okay? And that might mean that you have to explain a lot of stuff step by step to these bystanders, but that's okay. Again, monitor ABCs, use the pediatric assessment triangle, make sure that we use the MyMedic cards, be prepared to ventilate the patient if needed. If we get there, perhaps not an epiglottitis patient, but we have an RSV, a croup, or bronchiolitis patient, we get there and we hear some wheezing, let's go ahead and do the appropriate thing for them as well per protocol. Okay? If you have any questions whatsoever, don't hesitate to reach out to me.